So I'll be talking about something new, which is Pachyvitelliform Maculopathy, the new AVL on the block. So by definition, PVM basically means it's a phenotype subset in pachychoroid spectrum, and as the name suggests, it's pachy. So there is a thickened choroid with dilated halous layer vessels, and the vitelliform lesions here are acquired, and these acquired vitelliform lesions basically present as subretinal yellowish lesions composed of the material. So coming to the pathogenesis, we have the pathogenesis basically there is a thick hallous layer at the pachy vessels, and they tend to compress the choriocapillaries and the choriocapillaries, leading to RP stress. This leads to dysfunctional RP regulation, leading to accumulation of photoreceptor outer segments. And this, along with the melanolipofuscin, we get vitelliform material. So basically, there is this long-standing SRF which leads to the thickening of the ellipse zone, and along with there is suspension of the vitelliform lesions in that space, and that slowly that settles onto the RP, then it consolidates, and that leads to hyperreflective foci at a later stage. So coming to the evolution of vitelliform lesions were mentioned as early as in 1905. Then we had our pachychoroid spectrum disease, initially started in 2013. And this pachychoroid maculopathy was lately diagnosed in the last couple of years. And these are the two papers where I'll be having I'll touch upon as to what it is. So first, before that, the pathognomic imaging findings, as I said, was on an SSD OCT. You will see a hyperreflective subretinal material overlying these pachy vessels. And when you do an FAF, you'll see this hyperautofluorescence, which matches the deposits. Where the ICG will show choroidal hyperpermeability, and the choroidal thickness would be more than 350 microns. And they would have increased the CH ratio, that is the hallous to the center, the choroidal thickness. So this is the first study which was been later published in 2024, and they had 17 cases of PVM, and the findings were they had AVL all over these pachy vessels without any associated fluid. So fluid was not included in their study. The mean age of these sort of patients is more than 66th or the 7th decade. And in this study, the baseline visual acuity was 20/40, and over the age span of 33 months, the vision kind of dropped to 20/100. And as mentioned before with the definition, these were hyperreflective on OCT and hyperautofluorescent on FAF. And in almost 40% of these patients developed macular atrophy, and 64% showed RP disruption. So this is a classical photo which is taken from the paper itself. We can see these hyperreflective subretinal lesions, which corresponds to the FAF, which shows hyperfluorescence. And slowly over the period of 6 years, you can see that the subretinal hyperreflective material kind of regresses, and that leads to atrophy of the outer retina along with the RP. Now this is the study which was lately published by, we have Dr. Maria here, and it is her paper. And here she has, they had a retrospective study, and they have mentioned like they had a cohort of close to 1,000 patients, of which 5% are patients who had the PVM. So their mean age was similar to what was described before. And in these sort of patients, they did include patients with subretinal fluid, one. And the subretinal, the AVLs was mostly present in the subfoveal space, and in these patients had persistence of AVL over almost 50 months, and in this study, the vision kind of remained stable over the years. These patients had, as compared to the previous study, the atrophy was only 4%. So coming to some key associations which has been mentioned, these patients had kidney disease, where the chances of development of pachyvitelliform maculopathy can happen is kidney disease, having recurrent fluid episodes, thinner outer nuclear layer, patients with choroidal folds, as you can see in the photograph, and pattern dystrophy features on FAF. The patients, almost 30% of these patients had disappearance of the AVL over the span, and the features which helped in disappearance were gravitational lesions or focal hyperfluorescent spots on ICGA. And features with reduced AVL disappearance were basically subfoveal lesions, higher Haarler's to choroidal thickness ratio, and increased peripapillary choroidal thickness. The point to note is no influence of PDT or anti-VEGFs was seen when you had these AVL lesions. This is just a comparison between the two studies where they agreed on the definition as well as the imaging. In the study by Dr. Maria, they had a stable vision over time, but with Drs. Healy-Lees, there was a decline with atrophy seen. So to conclude, PVM is chronic, slowly evolving. It's seen in the later stages of like 6th to 7th decade. Normally has a stable vision, and complications of MNV and atrophy are comparatively rare. Thank you.